What is PGT-A? Pre-implantation Genetic Testing, PGT, for Aneuploidy A, is a mechanism for embryo selection which allows for better IVF outcomes. Eggs are fertilized, and the resulting embryos are grown within the laboratory for a period of 5 to 6 days. This allows for the embryo to reach the blastocyst stage. In the analysis of the chromosome number using PGT-A, the DNA is extracted from a few cells removed from the outer layer of the embryo, a trophectoderm TE biopsy. The trophectoderm cells give rise to the placenta and membranes of the future pregnancy. The inner cell mass, ICM, gives rise to the fetus/baby in the future pregnancy. Your embryo does not leave Vitalab. Cells taken from the trophectoderm are sent to outside genetics testing companies, FutureGen or Next Bioscience. The rest of the embryo is frozen and does not leave Vitalab. These embryos are stored, awaiting the outcome of the genetic testing results, which take approximately 10 days. The payment for the genetic testing is billed and paid directly to the relevant genetics company performing the test. What does PGT-A test for? The genetic code, genome, for building a human being is held within the DNA. This DNA is arranged into chromosomes. The normal number of chromosomes is 46, arranged in 23 pairs, and is called euploid/normal. There can be an abnormal number of chromosomes called aneuploid. If there is an additional chromosome, trisomy, then 47 chromosomes are present. If there is a missing chromosome, monosomy, then 45 chromosomes will be present. Avoiding aneuploid embryo transfer, there are only 3 possible outcomes for aneuploid embryos: no implantation/no pregnancy, miscarriage, survivable genetic syndrome. There are no healthy live births associated with the transfer of aneuploid embryos. These embryos cannot autocorrect themselves to become normal. The trisomies and monosomies that lead to children born with syndromes include trisomy 21, Down syndrome; trisomy 18, Edwards syndrome; trisomy 13, Patau syndrome; monosomy X, Truner syndrome. What happens during PGT-A? The trophectoderm cells are broken up, releasing the chromosomes from the cells. The DNA from the chromosomes is then further broken down into smaller pieces. The length of these pieces is defined and is referred to as a library. Since the DNA from a few cells is a very small amount, the DNA is amplified, a process whereby multiple copies of each DNA piece are made. During the process of DNA amplification, new DNA strands are formed from the most basic building blocks of DNA, the nucleotides. These nucleotides can be fluorescently labeled and detected when they are incorporated into a new DNA strand. This allows for the number of DNA strands to be counted, copy number. This copy number is compared to a normal 46 chromosome blueprint, reference library, and any deviations are highlighted as missing or additional copies. Next generation sequencing, NGS, uses high-resolution imaging technology to compare included nucleotide signals from the tested embryo to a known normal sample. A genetically normal embryo will be identified as having 2 copy signals for each tested area. Aneuploid embryos will show 1 or 3 copy signals, indicating missing, monosomy, or additional trisomy respectively. A normal read depth/copy number NGS result, A, with corresponding normal karyotype, B. In cases of aneuploidy, the abnormal read depth/copy number is represented by a deviation from the normal copy number, 2. In both cases, a trisomy, 3 copies of an individual chromosome, is illustrated. There is considerable overlap of signals, a phenomenon termed signal noise. Cutoff values for embryo allocation must consider this analytical noise. Euploid embryos, less than 20% abnormal copy number detected. Aneuploid embryos greater than 80% abnormal copy number detected. Why does aneuploidy occur? During the formation of eggs or sperm, the number of chromosomes is halved from each parent, 46, to yield an egg or sperm containing half, 23, the chromosomes. This process is called meiosis and is error-prone, leading to the uneven separation of the chromosomes. When this happens, an egg or sperm can be created which contains an additional or missing chromosome. The consequence of a missing or additional chromosome in a sperm or egg will be an embryo with 45 or 47 chromosomes. This situation is associated with adverse outcomes if an embryo is transferred into the uterus. No implantation/lower pregnancy rates following single embryo transfer. Miscarriage in the pregnancy following embryo transfer. A survivable syndrome being detected at the 12-week/NT scan. Down syndrome, Edwards syndrome, Patau syndrome, or Turner syndrome. Advantages of PGT-A. 1. Higher pregnancy rates? Genetic testing prior to performing an embryo transfer allows us to avoid using abnormal embryos. This allows for better selection of embryos for transfer and is associated with a higher pregnancy rate when transferring a single embryo. 2. Lower miscarriage rates. 70% of pregnancy losses/miscarriages occurring in the first trimester, 0 to 14 weeks, are due to abnormal embryo genetics. These can be excluded through genetic testing prior to embryo transfer, avoiding miscarriage associated with an abnormal number of chromosomes, aneuploidy. 3. No syndromes. With PGT-A testing of embryos, there is a 99.98% elimination of all risk for Down syndrome, Edwards syndrome, Patau syndrome, or Turner syndrome. These are the 4 survivable syndromes associated with an abnormal number of chromosomes. Historically, these syndromes were detected through a combination of blood tests and ultrasound at 12 weeks of pregnancy, the NT screen. This test identifies women with a high risk of a syndrome in the pregnancy. For a definitive diagnosis, an amniocentesis was performed, aspirating amniotic fluid from the uterus. Once confirmed as a syndrome, a woman was offered medical termination of pregnancy. PGT-A can avoid this situation as it relates to Down syndrome, Edwards syndrome, Patau syndrome, or Turner syndrome. 4. Sex selection. It is possible to select the sex of the embryo being transferred. Legal background to sex selection in South Africa. The 2012 regulations relating to IVF prohibit the use of a pre-implantation (PGT-A) or prenatal testing (NIPT) to select the sex of a child, unless it is for medical reasons. The Surrogacy Advisory Group challenged the ban on non-medical sex selection. They argued that the Choice on Termination of Pregnancy Act, Choice Act, allowed women in South Africa the freedom to terminate a pregnancy for any reason. That included termination of pregnancy following an NIPT test at 10 weeks. This allows for prenatal gender selection through termination of pregnancy, a process associated with potential bodily and emotional harm. They suggested a revision of the position of the Minister of Health regards the selection of gender prior to embryo transfer. The court's judgment was that while gender selection is inherently sexist, a woman's right to procreative freedom allows for first trimester termination without reason, including sex of the child. It is unreasonable to allow for prenatal gender selection through the Choice Act, but to disallow pre-implantation sex selection. Sex selection is now seen as part of reproductive autonomy and is legal. Note: the selection of an embryo with an XX or XY genetic sex requires the presence of functional gonads and steroid hormone receptors to allow for normal female or male development. Although rare, the absence of receptors for male hormones, androgen receptors, would mean that a XY male sex embryo could develop as a female. PGT-A would not detect or prevent this. 5. Cost saving. For the same cost as a single embryo transfer, you can genetically test approximately 5 embryos. This allows for the selection of embryos with a better potential for transfer, avoiding unnecessary transfers of untested embryos with no potential for a healthy live birth. Testing embryos through embryo transfer costs more time, emotion, and finances than using PGT-A to select embryos beforehand. It also avoids the situation of paying storage fees for frozen embryos, which are genetically abnormal, and therefore of no future potential. Limitations of PGT-A testing. It is important to understand where PGT-A fails to detect serious genetic abnormalities. The sum of all the chromosomes together constitutes the human genome. The building block of DNA is the nucleotide, which are paired structures. There are over 4 billion of these nucleotide base pairs. If a single nucleotide is missing or substituted in the wrong order, this is called a point mutation in the DNA. There are over 7,000 single gene disorders arising from point mutations. PGT-A detects the presence of chromosomes, not the presence or absence of the base pairs, so will not detect any single gene disorders from point mutation. PGT-A will not detect any of the over 7,000 described genetic conditions associated with point mutations. The distance between fluorescently labeled nucleotides, used as markers for each library strand of DNA, determines the resolution limit of the test. Missing DNA below this size will not be detected. The resolution of the tests are in the region of 2 to 4 kilobits, 2,000 to 4,000 nucleotide base pairs. Disadvantages of PGT-A. PGT-A is an additional cost, over and above the IVF cycle. PGT-A does not guarantee a pregnancy, rather a higher probability of pregnancy per transfer. Implantation is affected by factors outside of embryo genetics alone. PGT-A is not a guarantee of a healthy baby. PGT-A confirms the presence of a normal chromosome number, 46 chromosomes, within the cells removed from the trophectoderm biopsy of an embryo. The sensitivity of the test, resolution, will detect loss down to a certain size. Below this size, the test cannot detect chromosomal loss. In addition to the possibility of undetected loss, human development can be influenced by the intrauterine environment. Exposure to ionizing radiation, X-rays, certain medicines and chemicals, teratogens, dietary deficiency, folic acid, maternal infection, bacteria, viruses, protozoa, drug and alcohol use can all spell disaster in an otherwise genetically normal pregnancy. Even in the absence of exposure, the genetically normal embryo can exhibit abnormal intrauterine development. The DNA provides the blueprint or plan for creating a baby. That plan must be put into action to achieve a healthy live birth. This requires the interaction of billions of cells, intercellular messages, differentiation and specialization of different cell types. Any one of these could fail to occur, despite a full complement of chromosomes being present. Embryo developmental abnormalities can include structural and functional abnormalities of organs, the central nervous system, skeleton, soft tissue, and metabolic pathways necessary for healthy development. None of these would be detected, predicted, or prevented using PGT-A. Is PGT-A necessary? Initially, PGT-A was offered under very specific conditions to a select group of patients. Maternal egg, age greater than 38 years. History of recurrent miscarriage, greater than 3 consecutive miscarriages. History of a live birth affected by a genetic syndrome. A partner with a structural chromosomal abnormality, balanced translocation. Couples with a known shared carrier status or a recessive condition. Couples with a known sex-linked condition. For all other so-called low-risk individuals, PGT-A was not considered as being indicated. In unselected, low-risk individuals, PGT-A has not been shown to improve the cumulative live birth rates in women below age 38 years old. Provided a patient is willing to face several embryo transfers, including some negative, no pregnancy transfers, and some ending in spontaneous miscarriage, you will eventually end up transferring an embryo which will give a pregnancy. Ultimately, after use of all the available embryos, the cumulative live birth rates will be the same as if PGT-A was performed. The PGT-A group would reach the live births with fewer embryo transfers, less negative, no pregnancy transfers, and less miscarriages. This ultimately saves time, cost, and emotional trauma. The decision to perform PGT-A is entirely yours to make. After weighing up the risk/benefit ratio and the costs, time, emotional, and financial, the decision is entirely your own. How can I reduce the cost associated with PGT-A? The testing of embryos is associated with a cost for each embryo. You will be provided with a per-embryo quotation to help plan. In the event you have several embryos available for biopsy, can choose to reduce costs by limiting the number of embryos that are biopsied, freezing some of these embryos as untested embryos. Here, the lab will prioritize embryos for biopsy, choosing the best grade embryos. Alternatively, you can choose to biopsy all the embryos and amplify and store the DNA without performing the PGT-A test on all the embryos. This stored DNA will be available to run the PGT-A test in the future, should the need arise. These options should be discussed with your treating doctor and nurse coordinator. If I choose PGT-A, how many embryos should I biopsy? Based on female age, your treating doctor will be able to guide you as the average number of embryos you will need to test to detect a euploid embryo. Based on your age, the potential of a single euploid embryo to yield a pregnancy, and the total number of children you desire, your treating doctor will guide you as to the likely number of embryos you should biopsy.